Everyone, and thank you for joining us today. I'm Carol Warshaw. I'm the Director of the National Center on Domestic Violence, Trauma, and Mental Health, and we're delighted to have you join us for today's webinar, which is part of a joint series on opioids, trauma, and domestic violence that's co-sponsored by us at NC-DVTMH and CTIPP, the Campaign for Trauma-Informed Policy and Practice. Today's webinar is on the Opioid Epidemic, Social Determinants, and Practice Implications. This webinar will discuss the social determinants of the current opioid epidemic, with particular attention to how opioid use relates to an increased rate of deaths of despair. It will also discuss how a trauma-informed approach that takes into consideration all aspects of a person's life is essential in responding at both individual and systems levels. So we're very excited to be able to talk about the societal factors that contribute to the opioid epidemic. Today's speakers are Dr. David Labby and Dr. Lyndra Bills, and Sandra Bloom will also be facilitating and sharing the Q&A with me. Dr. David Labby is the Health Strategy Advisor for the Health Share of Oregon, which is the Medicaid Coordinated Care Organization serving 320,000 enrollees in the Tri-County region around Portland, Oregon. Dr. Labby has worked in Medicaid managed care for the last 2 decades with a special interest in delivery system transformation and the care of individuals with complex medical and social needs, which has led him to focus on the impact of trauma on health and, more recently, the healthcare system's role in addressing addictions and the opioid epidemic. Dr. Bills is a board-certified psychiatrist who completed an internal medicine and psychiatry residency at West Virginia University. She also completed 1 year of a specialized fellowship training in post-traumatic stress, also at West Virginia University. Dr. Bills worked with and helped to develop the Sanctuary model of trauma-informed care, and she is currently a regional medical director for community care behavioral health. She supports integrated practices for wellness and recovery using trauma-informed physical and behavioral health collaboration. Before we get started, I'd like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab in the center of your screen. You could switch to the screen from the slides by clicking the down arrow next to Using this Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or PC. On the right-hand side of the screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Angelica Medina, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options. But for this session, you'll want to select all participants if you'd like to respond to a question from the trainer or to contact center staff anytime during the session. You should also click on Angelica Medina to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Well, everyone, please go to the chat box, click on all participants, and type in where you're calling from, and then press enter. Perfect. Thank you very much. While people can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it up again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there's a media viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word media viewer, the same way you might if you want to hide the chat box. Time permitting, Dr. Bloom and I will be moderating the Q&A towards the end via the chat box. And at the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, Return to the email you received with the original webinar link and re-enter the webinar. Sometimes the sound cuts out due to internet connection, so feel free to call back in if that's a problem for you. If you're experiencing technical difficulties and are unable to contact Angelica, you may call WebEx Tech Support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. And thank you for joining us today. So I just want to tell you briefly about NCDV-TMH, and then I'm going to turn this over to Dr. Bloom, who will talk about CTIPP. As many of you know, NCDV-TMH is the U.S. Department of Health and Human Services Administration on Children and Family Violence Prevention and Services Administration funded Special Issue Resource Center on Domestic Violence, Trauma, Mental Health, and Substance Use. And part of what we do is promote what we refer to as an ACRTI approach for the DV field, which is accessible, culturally responsive, and trauma-informed approach, and an ACR-DVTI, a domestic violence and trauma-informed approach for the mental health, substance use, behavioral health, child welfare, and legal fields. We also provide an extensive array of resources and training and technical assistance, as well as research, policy development, and public awareness activities. In the opioid space, we also play a role in considering the role of substance use-related coercion and coercion connected with substance use and sexual coercion in people's use of substances. So I'm now going to turn this over to Sandy, who will talk about CTIPP.
Okay. Can everybody hear me? Okay. You may not have heard of CTIPP before. We're the Campaign for Trauma-Informed Policy and Practice, relatively new organization, and all volunteers. And our goal, we're based in Washington, D.C. Our goal is to advocate for public policies and programs at all government levels, federal, state, local, and tribal levels, that incorporate up-to-date scientific findings regarding what I assume are the things you're interested in because you're tuning into this webinar, the relationship between trauma across the lifespan and a wide variety of social and health problems in our nation. So in addition, we work in collaboration with communities, cities, states, and tribes to develop trauma-informed and prevention-focused policies and practices that reflect experience in the field. And we would love to have more people volunteering to join us. So please go to our website at ctipp.org and join us. Okay. All right. Now let's get started on this webinar. And I am going to turn over all to David. If I can make this thing work. Okay. There we go.
Hello there. I hope everybody can see me, or hear me at least. I need to move the slides. There we go. So this is a presentation that I gave last May. I'm the medical director at at the largest Medicaid managed care organization, which we call Coordinated Care Organizations in Oregon. And last May we had a statewide convening around the opioid crisis, and I was asked to give sort of a framing presentation around how to think about the crisis. And so this is aimed mainly at the healthcare system, but what I tried to do was to try to take them from where they're at, which is really thinking about their prescribing practices and a lot of conversation about the role of the healthcare system to a deeper level, sort of walking them through the logic of that. So where I started was really acknowledging that we all acknowledge what we have done in healthcare. We have fueled what is one person in healthcare called the worst man-made epidemic in modern history. You can see the numbers of deaths, the thousands of overdoses, et cetera. So in terms of the paradigm that people came to this conversation with last May, it was really as prescribers, as medical providers. And certainly that's a huge important factor. If we can see the correlation between opioid sales, which are driven by prescribing, and opioid deaths. It's a pretty consistent acceleration starting about 1999. We can also see that We have, in a certain sense, filled communities with pills. We were very busy writing prescriptions for many, many years, mostly hydrocodone and oxycodone, Vicodin and Percocets. And really, it was a huge launch into the community of a large volume of pills that we prescribed. And, of course, at the same time, we saw the evolving overdoses that followed that. However, if you look at this, this is a really interesting slide. The top gray line that you're looking at, which is natural and semi-synthetic opioids, or the Percocets and the Vicodins we talked about, but you can see that around 2010, something else started to happen, which is there was a huge increase in the use of heroin and heroin overdoses, and following that, as we all know, this whole introduction into the illegal market of synthetic, illegal forms of fentanyl. And that has fueled a whole other sort of sub-epidemic that isn't really driven by prescription opioids in and of itself. So something has happened. The story here is, yes, we started this epidemic, and there was something in the environment that fueled the epidemic, but it's not simply a question that if we change our prescribing habits, the epidemic will be over. And that was sort of the key message I wanted to get across to people who were prescribing. So when you look a little deeper, it's the non-medical use of prescription opioids that is the strongest risk factor for heroin use. So people with prescription opioid abuse and dependence are 40 times more likely to use heroin, and only a small percentage of non-medical users transition to heroin, 3 to 5%. A majority of the people who actually are current heroin users did initiate their opioid use with using prescription opioids for non-medical use. I mean, one could easily say this is true because we filled the communities with a lot less of drugs. And heroin is, prescription pain pills are much more potent as gateways to heroin abuse and dependence than alcohol, marijuana, or other things we might think of as substances of abuse. And this is a CDC slide. So clearly, we played a huge role. We primed the pump for something. When we looked at, in Oregon, who is using prescription opioids for what, we found that this is done, I think in around 2012 or so, 20% of Oregonians had chronic pain, and in 2016, 1 in 4 Oregonians had received a prescription for opioid medications. And non-medical use, we were tied for second place in the nation in terms of non-medical use. So if you do the math around the people who are using prescription opioids non-medically, 3 to 5% of the 212,000 people who, the 5% of the population, you get 6 to 10,000 people transitioning to heroin. So it's actually, we have played a huge role in this. And it's interesting this is a national study, but if you ask, well, where do people get their prescription opioids that they use for non-medical users? I hope you can see this slide, but it's that gray bar on the left consistently is from a friend or relative. So we were writing prescriptions. They were being put into medicine cabinets, which were leaving the medicine cabinets. They were also being given from friend to friend for non-medical uses. So obviously, the medical approach to this is we need to reduce prescription pain opioid we need to reduce opioid prescribing, which we've done. We focused on those people at most at risk and really high doses, where we have adopted as a state the CDC guidelines, and we have recently created our own guidelines around acute prescribing. So people who are dealing with acute pain or emergency departments have guidelines as well. And we as others are working to ensure access to medication-assisted treatment. We can get back to that later, and we certainly have expanded access on a lot. So very medical. But this is all, I would say, a very medical approach to the epidemic, and again, it sort of fits the paradigm, and that's sort of the predominant paradigm. At Health Share of Oregon, you can see over the last number of years, we've reduced the number of pills we have prescribed per adult member by 43%. We have a long way to go, but we have we focused first on those people on the highest doses, titrating them back, many times keeping them on their doses, but bringing them back to safer doses in a very slow titration process. And really raising awareness that we can't be as liberal as we had been in the past in terms of prescribing prescription opioids. We are also working on medication-assisted therapy and making access to buprenorphine in primary care much more available. You can see the little orange dots are the capacity of the state. This shows that Oregon has a lot of dependence and not much access, and that's been our start point. We now have some systems have vastly increased the number of waivered providers they have who can prescribe buprenorphine in primary care. Our challenge now is there is, in the primary care community, discomfort in dealing with addiction. Addiction medicine has not been part of primary care. This is really the opportunity to introduce addiction medicine into primary care, but there's so many issues around stigma, around fear, around lack of knowledge, around lack of competence, around lack of support that we're dealing with. But that's one of the major things we've taken on sort of as a medical system. But I think the fundamental question here is not simply how can we stop prescribing so many pills? How can we move from flooding the communities with pills? How do we get them out of people's medicine cabinets, get them move away from having them being freely available? So really asking the question is, why do so many people want these pills? What's the attraction here? Why? Because it's not simply that we were prescribing them in a particular environment where they were anxiously sought in a way. So what is interesting here is the work that has been done by Professors Ann Case and Angus Eaton at Princeton University. And it starts with their recognition that there was an increased rate of mortality in the United States among whites, ages 45 to 54. I hope most of you are familiar with this, but I'm going to go through a little bit of it in any case. So this increasing mortality, which started somewhere at the end of the 90s and continues today, is not seen in other countries. So there's something unique happening in our environment that is increasing mortality. And when they drilled down, they found it wasn't simply all white. It's not all whites, non-Hispanic whites, but particularly whites who have a high school degree or less, right? And when they went deeper than that, what they were dying of, these whites, was what they called deaths of despair: drugs, alcohol, and suicide. So this is what connects to the conversation about opioids, that you can see both for men and women, the rate, the mortality and morbidity rates of those with a high school degree or less, men or women, is much higher than men or women with four-year college degree or less. So there is what they called this epidemic of really deaths of despair. And again, if you look at this across countries, again, it is pretty much, there are some trends like this in the United Kingdom and Canada, but there's something particular happening in the U.S. And here is one of their graphics that shows from 2000. This is what the rate of deaths of despair were in 2000 in the ages 45 to 54. And here is what it looks like in 2014. Dramatic changes. And all of you have this county by county. We showed many of our providers what was happening in their counties and their communities, that this was an issue not somewhere else, but it was an issue in their communities. There's very few places in the United States where this is not an issue. So the question that they had to answer was, why is this going on? And here is basically a reduced version of their explanation. They correlated this, and they don't have data to support this. This is their hypothesis, that the decline in blue-collar jobs since the 1970s, especially for those with less than a college degree, has had a major impact on communities, especially for white working-class men. Fewer jobs, lower wages, lower returns on experience, which means that if you're trained as a welder, if you're trained as a crane operator, there's fewer opportunities for you to use your skills. That correlates, and they have the data on this, reduced marriage rates, higher divorce rates, increased reports of poor health, increasing poor mental health, increasing incidence of chronic pain, loss of social and economic supports, increased suicides, increasing substance use. And their language was, this process was unfolding before heavy-duty prescription opioids flooded the market, but their presence has heightened the impact. So in a certain sense, you have a perfect storm of two societal processes. One of the societal processes happens within the healthcare system, which is, I guess in retrospect, we would say the whole misunderstanding and inappropriate marketing of pain medications to the healthcare community, and the avidity with which we all in healthcare, including myself, started prescribing for chronic pain, thinking that we had a low-risk way to deal with some of our most difficult patient problems. That's one part of this. But the other part of this is what's happening to the basic social framework that we all live in. And, there's many political reverberations of this same story, but this is part of a larger societal process. And the epidemic is not one of the messages that I was trying to convey to the audience. Is the epidemic is not going to be dealt with simply by changing prescribing habits, which we and I think other states and other communities are doing and have more to do, but we are certainly down that road. And there are tools for us. People are rethinking how they're managing chronic pain, what kinds of alternative approaches they need to chronic pain to give people relief that is less risky and more evidence-based. So, but that is not going to be sufficient. And so if we, in fact, want to address the issues that our patients are presenting with, we need to think more deeply about the problem. So at the same time this was happening, we as a coordinated care organization were working with a population of what we call high utilizers, part of the coordinated care organization model, which was passed in a bipartisan way in 2011 in response to the 2008 recession. Part of the model was that all the Medicaid organizations needed to focus on what we were calling high utilizers. And so we did that. We got funding. We were fortunate to get a large grant to be able to do this. And as we got to know in a deeper and deeper way the population of people we were calling high utilizers, mainly by creating new models of care that put more resources into the communities, whether taking them out of hospitals, taking them out of primary care, connecting them to primary care, still connecting to primary care and hospitals, but moving them much closer to the patients and patient communities, understanding their story. We understood that the life experiences that people were undergoing were hugely determinant of their health outcomes, and we got more and more interested in asking what this is all about. So, of course, we knew the Adverse Childhood Experiences study. For some reason, Oregon has had a long sort of statewide conversation about trauma-informed care and ACEs, so it was fairly well known to us. I'm sure everybody on this conversation knows this study, but clearly it has it demonstrates, and multiple reports and studies have demonstrated a strong correlation between early life adversity and later substance use. And I'm going to pass this to Lyndra. I'm going to do this correctly and let her see. There we go. Does that work?
Well, yep. Yes. Hi, everybody, and I appreciate that. I wanted to just add that, in talking about such an important topic and the correlation between adverse childhood experiences, which a lot of folks are recognizing now, that link to substance use, that it's really important to know that in folks who have experienced a lot of adversity and especially more significant traumatic loss or specific events, that part of the substance use and use of other things to solve emotional issues or symptoms that are really common to the traumatic stress or PTSD as a specific issue, that's what happens. In other words, some people will be thinking about or try substances of all kinds to settle down some of those symptoms. And that's something that in the medical field, there's been a need to pay attention a little bit more to that specifically. And certainly we know folks who can have a traumatic stress issue as well as their substance use as comorbid condition. I'll leave it there for now. Let's see. Need to pass it back to David. Do you have that now, David?
Not yet.
Okay.
Ah, good. Now
There you go.
So, thanks. We have a little bit of technology issue. So what we actually started by doing one-on-one interviews with some of our quote-unquote high utilizers. And, this is I can go through this, but this is a story that was very, very typical. Here's a 47-year-old woman, 6 children by the time she was 15 or 32, but I don't know if you can see the small print in this, but she had a very, very, very traumatic, unstable early childhood. Her parents split up by the time she was 5. She kind of got left behind. She reconnected with her mom after many, multiple caregivers. But when she moved back into her mom, she started suffering sexual abuse from her stepfather. She ultimately ended up having her first pregnancy with a stepbrother by age 15. She dropped out of school. By the time she was 18, she was using drugs heavily as well as selling drugs. She had 3 children by various abusive husbands and living in very abusive households before her 20s. And she ended up going to prison. She had a suicide attempt, 3 more children, heavy alcohol, drug, et cetera, use. And by the time we saw her, she was starting recovery. Very multiple psychiatric medications, chronic pain, cancer, multiple surgeries, lots of trauma. We did 70 of these individual interviews, and they were all very different, but they were all tragically the same. And then we decided that there was enough here that we needed this we needed to dig deeper. And so at that point, what we did is we actually launched a survey. We sent a survey out to 10,000 of our members. We got 38% response rate. It asked all the questions of the ACEs, but it also asked, about childhood homelessness. It asked about school experience, about drug experience, and so on. So we really trying to get at the question of what has happened to these people so that they were being perceived as high utilizers, but more and more they were really more accurately described as trauma survivors. So some of the data we got back, and I should say that the real the importance of this data was we were sharing this with our board of directors, with our community, and we were helping people understand that these high utilizers were a subset of people who are in our Medicaid plan who had had very, very hard lives. When we looked at the overall health share members, 43% had 4 or more ACEs. That's compared to the national average of 14%. Everybody knows that Medicaid is higher, but it's one thing to say Medicaid is higher, but it's another thing to say our community Medicaid members have 43% have 4 or more ACEs. And, of course, the highest are physical abuse and neglect, substance use in the household, divorce. Only 20% of our population reported no ACEs. That's whereas that's half of the report nationally around no ACEs. And you can see some of the other things we found. Lots of struggling in school. 33% ran away from home. I was astounded by the number of people in our population that had run away from home. Now, some of them came back, of course, but they reported running away at home at some point. Huge amounts of substance use in the overall population. This is not high utilizers. This is just this is a sample of our general population. 28% had started substance use in childhood. 41% were homeless at some time, and this is Portland, Oregon. This is not People think of Portland, Oregon as not as hard an environment socially, economically to live in as some of the places in other parts of the country. So 41% have been homeless, lots of struggling to find work, not surprising given this is Medicaid, lots of verbal abuse, physical abuse, and 36% had been in jail. So to some of our stakeholders, this was not news at all. I mean, those who were working with who were social work backgrounds in the counties would say, thank God you finally got it. We've been trying to tell you this for years. But to others, this was a different way of thinking about our population, which was really a paradigm shift. Then we started saying, well, if we're interested in this high complexity, high cost group, what's their experience? As you can see, over 50% of them. This is really a group that has a very large percentage of ACEs. Many of them have 60% substance use, 55% homelessness, lots of jail, lots of abuse in their lives. So this is again a trauma survivor. And when you look at those people who have high ACEs and who are medically complex and high utilizers, you can see that there's huge drivers. This is a package. It's substance use, it's homelessness, it's incarceration, it's continuing abuse. It's really traumatic lives. And that helped people understand that as a Medicaid population that is responsible for over 50% of the births in the state, or Medicaid in general is responsible for over 50% of the births. We're 50% of the births in our region. A lot of young families, it was connecting the dots between the high utilizers that everybody wants to focus on, where all the money is, and the early childhood experiences that we see unfolding in front of us in primary care and other parts of the healthcare system, to which we do not respond mostly. I'm going to turn this back to Lyndra, if I can do that.
Yeah, I gotcha. Thank you. And I was just going to mention, somebody was asking if we could hear anybody on the line out there, and I would say no. It's quiet, so somebody asked about that. So let me move back to your good focus on this challenging area. I think it is really important to recognize that, especially when people have adverse experiences, the younger they are, if that continues throughout a person's life, which you really highlighted well in that example, and for so many of the folks that we see, they've had years and years of adversity and severe stress, and that becomes cumulative for them physically as well as mentally or emotionally. And that's certainly in my experience, and if you review the literature, that's why you see so much of medical complexity as people have their traumatic stress experiences active and just building over time. So there's an important link between all that medical comorbidity and long time and years of having severe cumulative stress experiences, and then added on top of that the risk for substance use, and in particular the connection to opiate use. It's interesting to note that in specifically the area of chronic pain, which is one of the situations that does lead to higher use of prescription opiates, and then potential gateway for people to get into trouble with heroin and other substances. There may be a common pathway for those folks physically and in the brain related to that relates to both chronic pain experiences as well as PTSD and trauma, and that's through levels of anxiety. So one of the things that I'll add in at this point is that it's important for providers and helpers out there to recognize that one of the symptom groups that's really challenging for people who've had a lot of traumatic stress exposure and experiences is anxiety, and that's just a general way to describe it. It can be a lot more specific. But when that symptom area kind of goes along and doesn't seem to be helped in any way, that can lend itself to other particular areas of problems. And it's important for especially folks focused on substance abuse treatment to kind of pay attention to that. I'll pass it back to you, David.
Great. So, I mean, this is sort of our slide version of what the, oops, are we there yet? Great. So this next slide is sort of our version of the K-Steven narrative, which is, you know, as we've talked about, ACEs really set up a cascade of risks that happen. Stressed families, don't have housing insecurity, have a lot of insecurity, lots of stress in the family, high ACEs, poor social and emotional learning skills, struggle with schools, et cetera, and you can follow this. But really what I want to stress in this is that what this helps us understand is that while there is a medical narrative of this, there is also a social and policy narrative to this. Because if we think about the fact that these young families are coming to us, that women are coming to us who are able to have children, and we're not asking them what their pregnancy intention is, and we know the rate of unintended pregnancy in the Medicaid population is like 65%, much higher than the general population. In the African American community, it's more 85%. So if we're not asking about pregnancy intention, and they are not in any way prepared, equipped, supported to be able to have children, then that's sort of that's an organizational issue. This is not simply things that happen outside of there's social determinants of health that are happening outside our system. If we're not asking about food insecurity, we're not asking about ACEs, this is stuff that happens in our system. And there's also other systems. I mean, if you think about, we all know, I hope, about the issue of expulsions from school starting in preschool. Preschool, in fact, being one of the highest, had the highest rates of what we might call expulsion, especially for boys, especially for boys of color. These are all sort of social policy, organizational issues that are creating the pathway that leads people into being the trauma survivors that then at the end of this course, or as they need more and more medical care, we are paying for. And it's completely it's largely, we could mitigate those outcomes if we actually had aligned systems where policies lined up, where we supported people across the continuum, so we had a better safety net continuum. So part of the message is we can do our part as healthcare, and there's tons that we're not doing, but really if we're interested, if our goal is to reduce this population of high utilizers over time, the people who are using most of our healthcare dollars, we can't do this alone. We need to do this in conjunction with with not just the healthcare system, but the school system, the criminal justice system, the housing system, and it becomes a much different kind of problem than we just need to follow CDC guidelines about prescribing. And we showed this, we created this diagram, which we actually call chutes and ladders. So basically, this is what we've been talking about. Early in life, if a child is born into a situation where the parents aren't ready or able to parent, they have poor attachment, they suffer neglect, they are not ready for school, they're not ready, they can't read by the third grade, they have behavioral problems, they may or may not get expelled, but they don't do well in school. They start, and this is the story of the woman we talked about, substance use, unhealthy relationships, and this whole pattern repeats as they have unintended pregnancies and the second generation goes along. And this is just a cascade of adverse life events that derail people, partly because, yes, they make poor choices, but mostly because we only give them poor choices to make. And so this was the part of the chutes and ladders notion that we put in front of people, saying, many of us in this room didn't go down that path. Many of us have supported parents who made sure we were doing well in school. We were prepared for school. We had lots of books at home. They read to us every night. They made sure that we were prepared all through our adolescence for life as much as they could, and we had support throughout. Those are the ladders. Other people don't have that advantage. And so that, again, helped connect the dots between what our focus is, which is improving population health, lowering costs, the famous triple aim, and life experience, life course. So I think Lyndra has a few things she wants to add at this point before we move on.
Yeah.
Excuse me, I got to move it back to hold it.
No, you're good. I can just mention it. I basically was just going to confirm. I think that's a really good point. The whole issue about needing the bigger picture and community, broader community solutions, and for me that brings up the notion of resilience and why that's so important. And recognizing that that can be added and improved upon. So, for example, some work that was done in Washington State really highlighted that they measured the community's capacity to support folks who had significant adverse childhood experiences, and over time were able to really improve community supports and connections to target a lot of those earlier life issues that you showed on that slide. And that is a way to try to get at some of these other areas, not to minimize all the other important opportunities with prescribing, et cetera. I'll pass it back to David.
So that's where we're at now. I think that the opioid epidemic is obviously a huge challenge for the healthcare community, but I think it's also a huge opportunity. One of the major things we're talking about now, especially as we've gone through the changing in our prescribing patterns, we're seeing the reduction in the number of pills. We're not seeing we sort of stabilize in terms of the overall opioid overdoses in the state. But we're beginning to have a different conversation, which is the effects of this are going to be around a long time. This is multi-generational. And addiction is a chronic disease. We are not going to simply treat people as if they have an acute disease and be done with it. We have to bring addiction medicine into primary care. There was many of you may remember that in the early 2000s there was a whole initiative trying to introduce depression care into primary care. Robert Wood Johnson was one of the major funders of a national effort called Depression in Primary Care. We were all taught that we could use those drugs like Prozac and some of the other emerging antidepressants. But what it really did for us in our community was introduce behavioral health into primary care. So it wasn't just depression, it was anxiety, it was taking on behavioral issues. I think we're at another inflection point where this is the opportunity to introduce two things. Number one, trauma-informed approaches into primary care, because dealing with the opioid epidemic is dealing with trauma. There's just no other way to put that. And second, the primary care healthcare system, and generally all of the healthcare system is really not competent when it comes to addiction medicine. So this is a huge inflection point about introducing addiction medicine, especially trauma-informed addiction medicine, into primary care, which I think is really opening up a larger opportunity to really start having serious conversations about what population health is. There's lots of conversation about population health. The early conversations about population health really focused on, good issues, diabetes, healthy eating, exercise. But I think the Case Deaton work, the existence of the opioid epidemic, is really asking a more fundamental question of us, which is, what is happening in society that we are having overall increased mortality in groups that before were not having that? What is happening? And I think it opens up the whole question of what is happening to people in their communities, what communities are at risk, and how do we address trauma as a major health issue in a way that we have never addressed it before. So the healthcare system basically is still pretty much looks at this as we need to prevent addiction, as primary care We need to do more around addiction. We need to do more treatment and risk reduction. Certainly we are focused on expanding treatment, but more and more it is clear that we really need to have much more of an approach that is integrated with other parts of the healthcare system. Currently in our community, we are fortunate in many of the leaders in criminal justice now want to do buprenorphine in the jails. That is causing new conversations because they're saying, we'll do it in the jails, and your data and our data tells us that your high utilizers are our high utilizers, and your mental health population is our mental health population. But they're saying, look, we're willing to do this, but you have to be able to take the patients we start on buprenorphine or whatever, we start in treatment, and continue their treatment. Otherwise, there's no reason for us to do that. So that actually is catalyzing a conversation within the healthcare system, which is we need to align our own services so that people can actually get long-term treatment, and we can move much more to supporting recovery long-term. So we have now partnerships with the EMS system, public health, corrections, lots of conversations with the peer recovery community. Not much conversation so far with schools, but obviously that needs to happen. There is a sort of a related conversation going on around kindergarten readiness with schools, but not around the opioid epidemic. Foster care is another issue that is a huge crisis in this state where there's conversations. So I think the opportunity, if you will, of the opioid epidemic is that we will not solve the issues of the opioid epidemic by changing prescribing practices, and that's more and more clear. We will not solve the issues of the opioid epidemic by increasing access to treatment, which we need to do. We need to do both of those things, but much more than that is we need to have a much more trauma-informed, if you will, approach to population health than we ever have before, and change the conversation about population health from looking at it as a medical lens and really looking at it as a lived experience lens. I'm going to turn it back to Lyndra at this point.
Thank you. Yeah, I appreciate that. I agree. I think there's great opportunity to do more and be more thoughtful besides kind of just focus on changing the prescribing practices, and it is really important to have the whole approach, including making sure the approaches in primary care, substance abuse settings, et cetera, are trauma-informed. And what I was going to add is, for instance, it's really important to do screening about trauma in all settings if we're looking at population health approaches. But it's really important to be thoughtful about how this is done. And I think for a lot of systems, whether it's the clinic, the system, even just the individual provider, that they need a lot of support and help. And fortunately, there are a lot of great resources out there. But one thing that's true, when folks who've had significant traumatic stress experiences, even just asking questions, unlike something like typically depression or anxiety, asking questions, even using a screening tool, sometimes it can trigger some of the more complex symptom picture that may have been temporarily quiet. So it is important to think about these in our systems of care. And how do we approach this, but just making sure people are aware. The screener, the person that's got the role of screening, whether it's primary care or even mental health care or substance abuse settings, they need to have a lot of support and education, again, trauma-informed, to really have basic understanding of what that means so that they're prepared and have a plan for what folks need to do if the person does get overwhelmed by screening. So I think those issues are really important to pay attention to, and I think you're right. If you're having a more general population approach and being really thoughtful, then we make sure we include all those components as needed. I'll pass it back to you, David.
Okay. So, sort of to wrap things up, I think the framework of a recovery-oriented systems of care from SAMHSA and others is more and more what we need to think about as we approach the opioid epidemic. For us, we can start people on treatment. We can carry them through medical treatment. We can start them on various meds, give them all kinds of outpatient therapy. But recovery for this population that has lived through so many years of trauma is probably a community. It's going to happen in the community, and we're not very good at supporting community efforts around supporting recovery in the community. There are certainly organizations that do that in our community. There's too few. There's too few peers. There's too few culturally specific peer organizations that do that. But reintegrating people into society, into their communities on their terms has got to be the major piece of what recovery from the opioid epidemic is going to look like. And that's also probably recovery. That's probably a great model for how to build health. It's a community development model. It's much more of it's focused on developing skills within the community rather than the sort of expert medical system approach. And we are aware of this, and we're starting to have conversations about how we help the peer recovery system, the community-based organization system, be part of this. But it's more and more clear that the answer to the opioid epidemic is probably not in the healthcare system, and it's in those partnerships, and it's really in some form of partnering with communities and community development. So I think that changes, and hopefully that will change. I think that's true of population health in general. So will that change the conversations about population health that we're currently having that are basically very medical-centric? I don't know, but I think there is the opportunity there. And I think, at least in our community, it's one of the ways that we can change the conversations in the direction that was really intended for these things called coordinated care organizations, which in their initial framework were supposed to be partnerships between the healthcare system and communities, and that is obviously a work in progress. So to finish it up, here's the ladders, the chutes and ladders. Fortunately, I think many of us have had some version of this as their life experience. It needs to be said that when we looked at our data, not everyone with 4 ACEs ended up as a complex medical high utilizer. Actually, those people it was actually a small percentage, something like 15% of them ended up in that highest risk group. That said, 60% of the people with 4 or more ACEs ended up with chronic disease as compared to much lower rates for people who had no ACEs. So there's a huge health impact. But ACEs are not destiny. And going back to the point that there's a lot of the outcomes of ACEs are socially constructed. It's about the policies we have in place, is what we do to people as much as what they choose to do themselves. And those are the kinds of conversations which I think will allow us to have a productive conversation about how we make communities' health more healthy and more resilient, which is increasingly what people are talking about. And I think which opens up an opportunity for new kinds of conversations. So I'm going to leave it there, and I think I'm going to pass this back to Sandy. Boom, here we go.
Yeah, I just will add, I just was going to say that you're right. I think the ROSC, or the Recovery-Oriented Systems of Care, is, that kind of woven collaboration of all parties in service of best possible health is a good way to think about it. And you would include screening and managing traumatic stress reactions, whether you did it directly or you passed that along to people who could handle that and support the person. But you need basic trauma-informed education for the systems as a whole, all healthcare, when you're looking at population approaches, and access to trauma-specific methods and tools when those are needed and appropriate. And I think, for example, in the population, we're kind of honing in on the people with significant substance use issues. For example, Seeking Safety is a great resource and has been successfully used for both the provider and clients, and something that's really accessible. But there also has to be support for something I refer to as complex problem solving, so needing to have in our systems of care that there is support for trauma-informed supervision. And because that element is one of the ways to address the complexity that gets to be overwhelming for the individual provider. And I appreciate the opportunity, and I'll leave it there. I'll pass it on to Sandy.
There. Okay, I think now, can you guys hear me? Thank you, both of you. I deeply appreciate what you were talking about, connecting basically the personal and the political. And I'll take my privileged position before I turn it over to Carol, who has collecting questions, to ask a question myself based on what you've both been talking about. And now that the federal House has changed hands, I'm wondering what do you have any ideas about going forward, what in the state level and the federal level, what kinds of policies might be worth really advocating for? And I want to take a minute to encourage everybody on this call to if you can get your legislators or their staff to listen to this webinar, it would be a real step forward. So, but let me, David, if you would kind of take that for a minute.
So I'm not going to talk about our experience. There are so many burning platforms in this state, as in every state. Foster care is a burning platform. There's a lot of interest in the foster care situation. It is we know that 70% of the kids who go into foster care, their parents have some substance use issue. I think, in certain sense, the issue of the moment is substance use and opioids. I think there is, when we talk about people adopting policies around trauma-informed care, they become much more effective if we can anchor it in what do we want people to do now. And I think the do now is really about addressing an epidemic. Many of us went through this various other bioterrorist, and other threats. And there was much more mobilization around those. And so the question is, if this is truly an epidemic and people are truly want to change it, that there needs to be funding, there needs to be national coordination, there needs to be direction. And I think, again, I think it's really hard it's so hard to talk about addiction and what's happening in communities without talking about trauma and this picture that is emerging from Case and Beaton and others, and that everybody is basically part of the political dialogue. How do we connect those dots for people? And the legislation has to be, I think, one of the opportunities for legislation is around substance use, is around foster care, is around very specific things where we can start moving some of those specific policy issues forward. I think also the more expansive is, we need national legislation around what we expect from schools. I think a lot of our schools are failing because they're dealing with communities that are so traumatized, and they're not dealing with the trauma kids bring to school, that we're not making any traction. So I think we have an opportunity to have sort of a national voice around, the deaths of despair are deaths because of people being traumatized. How do we change that? And I think the Democrats running the House may be open to that dialogue, and how do we lift that dialogue? I'm going to hand it back to
Carol.
Carol. I'm going to try.
Hi, I think we're all unmuted. Is that true? Can you hear me without the ball moving?
Yes.
Yes.
I can.
Yeah, the ball is just to advance the slides, and on this webinar we can't talk about anything that is partisan politically. So I just want to say this is a bipartisan webinar, but I'm looking in the chat box, and I don't think there are any questions Yeah, this is a Q&A that have been in there that people haven't answered. So let's hope any of you who have questions for our presenters, please enter them into the chat box so we can respond to them. And I also want to thank David, thank you, and Lyndra for a wonderful presentation and very thoughtful. I want to add a couple things while we're waiting for some questions. Two pieces of work that we tend to focus on. One is around coercion and the role of coercion in people's use of opioids and becoming addicted, in relapse and recovery, in the context of intimate partner violence. In our study with the National Domestic Violence Hotline a number of years ago, 27% of over 3,000 callers, women who were survivors of domestic violence, said the current or former partner had coerced them into using, and of the 15% who sought treatment, 60% of those said that their partners had tried to sabotage their recovery in one way or another. And when we think about the trafficking world, that we know that coercion into using opioids is one of the routes into trafficking in a way that people control either partners or victims of trafficking, whether it's for personal control, individual sexual exploitation, or for profit. So it's like there's another layer in there when we're thinking about this. And the other thing I want to mention is when we're talking about deaths of despair, the increasing rates of opioid-related overdose deaths in Native American communities is almost as high as in the white community, and also rapidly increasing trajectories of opioid-related deaths in the African American, Black, and Latinx communities. So there's lots of reasons for despair and lots of different constellations of how that takes place. So I think thinking about all of those together is really going to be important for thinking about public policy related to these issues. So I'm looking for questions.
There is one.
None of you have.
What's the average age of onset of users? David or Lyndra, do you know the answer to that question?
I do not, but I know that we have, from our data, we have a lot of people, there's almost 28% of what I can look at my data, but who started early. So I don't know what the average age, but I know that there is a shocking number of young people who are starting their course towards addiction way too early.
Yeah, I was going to say, I think it's right around pre-adolescence, or beginning of teenage years, 13.
And also the SAMHSA, NISDA, the National Survey on Drug Use and Health, the 2017 data is out now, and they do by age as well. So there's a lot of graphs and data that people could look at if you're so inclined. And the AMPFAR website, AMPFAR, has a lot of data by state and county as well. So, and beautiful graphs and maps.
There's one of the people's commenting about how difficult, challenging it is in rural areas to get sufficient services, that they're just not available for people. And Lyndra, I was wondering if you would like to address the whole BHARP project that's been going on in rural Pennsylvania.
Okay, sure. Yeah, in the most rural parts of Pennsylvania, central and north, we've been taking an approach to trying to address the need for trauma-informed services, and that's both for mental health and substance use. So we took a really large group of providers and targeted, using a learning collaborative model, we targeted getting them on board with screening for trauma, and then also learning trauma-specific treatment methods, so they could offer folks at least one, but hopefully two options. And then we also supported them having trauma-informed supervision, and then did a lot of basic trauma-informed education using the model by Lakeside Education Network to teach the broader human services folks in all these rural communities about basic trauma, and then they've developed things from there, and then we're supporting them sharing their expertise and collaborating with each other. So that's been positive so far. We really have seen a benefit from their learning about screening, which that one intervention made a lot of changes for these different providers who had to work through a lot of issues just to be able to do that.
Great. We also had a question about the use of body, mind, and mindfulness techniques with this population. I think that one of the things that this conversation really points out is the extraordinary complexity of the problem. So, although there are some evidence-based approaches that are quite effective in helping people, there's not enough yet to really cover all of the territory of complexity. So I think there's a lot of work going into, because trauma gets into the mind and the body, a lot of work that's going into trying to use alternative methods to help people. Do either anybody else want to make a comment about that?
You're right, Sandy. Go ahead. Go ahead, David.
Well, I mean, when, some of our clinics have set up groups for their identified high utilizers, as they call them, seeking safety. We can do a seeking safety group in primary care. You can do forms of DBT light in primary care. And when those occur, they're extremely successful. And it's always a challenge finding the right person to lead them, the funding model, et cetera. But there's no reason why that shouldn't be part of primary care. There's no reason why it has to happen in specialty behavioral health. And so I think there's lots of opportunities. While we don't have all the answers, there's so much more we could be doing with the tools that we currently have. But the issue is really getting the healthcare system, at least if you're talking about the healthcare system, to start adopting that. I mean, some of the work that's going on in schools is extremely, around social emotional learning. They have yoga, they have various curricula around social emotional learning. There's a lot we can know about in some of these school systems where they've really taken on teaching kids emotional control, trying to help them with the chaotic lives that they live on that we should be doing in primary care, and we could.
There is a primary care clinic here in Philly, 11th Street, that has been incorporating a lot of alternative therapies right into their healthcare provision. Go ahead, Lynn. I'm sorry.
I was going to say yoga, definitely. I mean, there's been some early work done by Dr. Vanderkolk that showed the benefit of yoga and the reasons behind that. And there's been, I think there's around 6 studies ongoing right now in the VA about using yoga, and certainly that can be beneficial. You have Pat Ogden's work with body-oriented psychotherapy, and certainly somatic experiencing, which actually kind of tries to touch on the body impact of trauma, mindfulness-based stress reduction, and certainly that approach can be helpful for a lot of folks. And I think one of the keys I always talk to providers about, when they're needing to address the individual who's got significant trauma, is that you need to be willing to use what is going to work. And there are many options, many different trauma-specific interventions. There's more now than there ever has been. And certainly if you learn about them and collaborate with, colleagues, not everybody's good at using all the different methods. That's my opinion and has been my experience. But, what's most important is for that person that you find something that's going to match what they need. So really paying attention to what the person may want to try or use, that requires the clinician having some expertise and knowledge about the different options, even if they're not going to use them.
There's another question here about the challenges of engaging healthcare providers and administrators. And the question is, from the medical perspective, what would motivate medical providers to, take this knowledge on board?
Well, what we found was what motivated them was when they understood on an individual basis, when they understood what was actually happening with their patients. A lot of the work that we did early on was using our staff who was doing the outreach in the community, a lot of them MSWs, to translate back to the providers who this person was and putting their life in context, because most providers are pretty stressed in terms of their time frames. They think they understand their patients, but they're making a lot of quick assumptions. And so one of the ways we introduce trauma-informed, we did a lot of training, we have done a lot of training to primary care around trauma-informed care, but the way into that was really having them look more deeply at the patients in front of them and having those patients' story sort of part of their understanding of who they were serving, why some of the interactions they were having were not going well, and what they might do to make them more effective. So, I think, and the study we did was really a way for our community to understand its population. I mean, mainly what medical systems do is they go to the billing and coding data and say, this is how we understand our population. And that is, certainly when you're dealing with poverty level, marginalized communities, that is such a limited view of the population and such a limited understanding that the challenge is really getting people to understand what has happened to people, and that's, of course, been said many times. But how do you do that in a palpable way at an individual and at a community, at a clinic level?
Another question is the issue of. Go ahead, Lynn. Sorry.
I was just going to add something to that. Medical providers, too, also, I think one of the things that's really helpful is to explain to them the reasons why we know trauma can manifest in the body and somatically. So I know this, even in Dr. Felitti and Dr. Anda's ACE, the original ACE study, one of the things that really helped was, the medical providers really getting a sense about why that would happen. And once they could understand that, that actually could make a difference in terms of their awareness. And there are a lot of good resources to get medical providers to really, if they're interested in kind of understanding it in a way, some more of in a sense like a scientific way, that's something that could be useful. Even Bessel van der Kolk's article, "The Body Keeps the Score," even that one article, which you can download free, is really useful for clinicians, and I found a lot of physicians found that really useful.
It's also really useful. The Center for the Developing Child has a couple of very brief videos that help explain the impact of ACEs on the child's brain and development. And in a very short period of time, you can help people understand why it's such a big deal. Okay, another question is an issue regarding trauma and sobriety. So pointing out that historically there's some people have taken the stance that dual diagnosis can't work, that you can't do mental health issues until a person is sober. And then, of course, you got the problem of people not being able to get sober because of their trauma issues. So any thoughts you have about that?
I'll say that's a really good question, and add that that was certainly a long-standing kind of approach. Like, okay, somebody's got both issues, they've got to get sober, and then we'll delve into their traumatic stress issues, their whatever those symptoms may be. But I think there is more widely recognized that you need to address both things. They're very connected. So that when if somebody gets sober, if say they're in treatment or in a rehab level of care or something like that, or elsewhere, but they may start having a lot of their trauma symptoms because those aren't being covered up by whatever substance was used. And then if they don't have any skills or resources to fall back on, then they're certainly at great risk of relapsing and getting back with the drugs. So you really do need to take time to address both issues simultaneously because the person is going to need those skills as they move through their recovery and sobriety.
Another participant is talking about the challenges when people are these families are court ordered for treatment, and they have to pay fines and try to get to the court, and they often give up and relinquish their rights to the children. And then, of course, they continue on with the addiction, and then we've got the issue of the foster care issue that David was referring to earlier. I think that's just a comment on the frustration that many practitioners encounter. And then there's a question of what type of resources or supports are available nationwide for individuals and families in crisis due to substance abuse. Are there any?
SAMHSA.
Right, and NIDA too.
Yeah.
You mean, and they can help find resources for individuals?
Yes, SAMHSA has there's a treatment finder, and then there's also the American Academy of Addiction Psychiatry SAMHSA has given them money to create regional technical assistance for people around the country who want to be more adept at providing addiction treatment, but they also may know of resources. And SAMHSA's regional training and technical assistance centers should also know. Also, many states, over 40 states, have women's services coordinators as part of their state substance use disorder treatment, whatever it's Department of Behavioral Health or whatever that's called in your state, and they would also know of resources available in the state. I was also going to say, I touched this in earlier, there's a lot of money going to states for opioid treatment. Some's going to public health and some is going to federally qualified health centers. They're going to different entities. And so I think kind of for those of you who are advocates to be at the table and thinking about how those policies are being shaped in your state and where the money's going and how to make sure everyone's at the table and that the complex issues that David was talking about are part of the discourse around how that money is being spent and used. There was also a question about if opioids are so addicting, why prescribe them at all? Because you don't have to have ACEs to become addicted. And so I'm going to ask that question. I don't know if either of you want to address that.
Well, I mean, the evidence is that the longer you use them, even on a short-term base, the higher the risk of addiction. There's also evidence that the higher the dose, the more chance of opioid, both of which make sense. I don't think we know and there's also evidence that we really don't have support for chronic opioid prescribing for chronic pain. And that may be a question of is there not the evidence versus there's evidence not to do it versus there's risk. So I don't know. I don't think we've really settled on what's the appropriate use. Certainly for acute pain, broken leg, trauma, physical trauma, short courses can be effective. And we have no evidence that prudent short courses should be avoided. So I think we're trying to figure out the appropriate use of opioids, acknowledging that we have push the envelope into inappropriate use. So I think that's a really good question. Should we use them at all? And I don't think there's a clear answer. So that's sort of the state of knowledge, I think.
I think there's a lot of effort to develop other kinds of pain medications that would not be as addicting, but I don't think they're quite there yet. But there is a lot of effort on those fronts.
It's an interesting question about a person that works at the medical examiner's office and doing follow-up calls with families whose loved ones have died from an overdose. And she's asking, are there people that it would be helpful for her to connect with to figure out what services are lacking for the loved ones that are left behind? Does anybody have any ideas on that or experience?
I mean, I know that we certainly have resources, again, like through the state or through, locally, even through the provider network or where, the family. There seems to be an emphasis, even with the substance abuse treatment folks. They're trying to pay attention to families and loved ones, knowing the impact of the loss of someone through overdose. So different communities. I was just at a community event where the community, and this was around Reading, Pennsylvania, but the community has made like they're supporting a hotline and a website where there's access to talk with somebody and have support if those are your issues, whether you need treatment or you're a loved one and you need some support. So they've made that resource for their local community.
For that, there may also be, CTIPP has a community advocacy network to connect so that people from communities can connect with each other about what's happening around all of these issues and what different communities are doing. So and
the Centers of Excellence, people might be familiar with that, and that's another initiative that's been driven by the need to focus on the opiate crisis, but they have a lot of resources for folks in terms of connecting them if they need help.
I'm looking to see if there are any other questions that we missed. I think we got most of them.
I think we got, other than, will there be slides available to print after the webinar ends? Oh, and there we have a link to get the slides.
So, any more questions before we end? Well, if there aren't any more, I want to thank you, David, Lyndra, and Sandy for today's webinar, and thank you to Angelica and Carla for making the webinar run smoothly. Last but not least, thank you all for spending your time with the National Center on Domestic Violence, Trauma, and Mental Health and the Campaign for Trauma-Informed Policy and Practice. Within the next week, we'll send you a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts that were referenced, all of which will be available on our website. You'll also receive a certificate of attendance for your time today. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, it would be greatly appreciated. I also want to say on our website, there's under webinars, the second one down is on our opioid domestic violence and trauma series. So there's the links to all of the webinars that have been part of the series are available now, and this one will be available in a few days. So if you could fill out the evaluation, we'd really appreciate your letting us know what was useful and what could have been better. So thank you again, and we hope you all have a wonderful afternoon.
Thanks, Carol.
Thanks.
Thank you.